Officially now. We're going to try to. I'll try to get skin finished up, and if not, I'll get it in the first part. In lab, I already have the bones out. We'll start playing identify the bones. I got to do some printing to give you a handout on the skull. I'll make it digital as well for you people who resist paper, which is fine. And these are now we're at the point where now we're at skin appendages, hair and nails. It's a different kind of keratin. It's a sturdier, it's a hard keratin. Your skin is more of a soft keratin. So there's variations that are in it that are there. And you can see there's limited. We have hair everywhere except for you can see palms, soles, lips, and lips more or less are mucosa anyway. They're not really skin. Nipples, which are skin, but effectively have the same kind of tendency as that, and portions of the external genitalia. To wit, just to give you an idea of why the skin is closer to internal there than external. When we look at, people used to think that HPV and cervical carcinoma that only affected women. It's absolutely untrue. I mean, genital warts have been around on male genitalia forever. I probably saw more cases on male than on female. It just happen to be external versus internal that are there. So it has the same degree of severity, the same tendency to form cancers that are there. Just to give you an idea contextually about all that stuff. And yeah, I mean, basically the hair basically it all has nerve endings. So anything that I may be in contact with, insects, whatever, physical trauma certainly, heat loss absolutely, shielding from sunlight no question. Okay, bless you. And I mean that's all those types of things. We're getting into what the problems are. Now this is just some other protection. So another name you see pili or pili, either way is acceptable. They're produced if the hair follicle is nothing more than a similar structure to when we see the enclosure of, even though it's buried deep in the deep dermis, the reticular or deep dermis, it's surrounded by an invagination, like an input, superficial dermis, and the hair follicle is in that. And the hair follicle is very much living. And that's when we do DNA analysis, follicles provide full DNA, hairs themselves very limited because typically they're dead hairs. You get mitochondrial DNA. So you can see a family, you basically get half the genetic picture. Because, obviously the mitochondria come from the mom. Sperm just makes a genetic contribution, not the organelle contribution. So hard keratin, unlike soft, tougher, more durable, cells do not flake off. Eventually, there are conditions where they do flake off. Most of the time, we have to cut them. Okay? The shaft, by definition, is what extends over the scalp, and it's complete. That's, we can trim and etc. like that, not worry about anything associated with being painful or annoying with that. The root is within the scalp itself, and that's where it's still going on. So you get the root all the way down into, you're going to see some of the anatomical structures. And here you get the first view of important language, term medulla and cortex. The medulla or medullary area is internal. Cortexes are external. In bone, the medullary area is where the bone marrow is effectively located. The cortical area is the outside sturdy area. That's when we talk about adrenocortical and adrenal medulla, when we talk about the adrenal glands. Cortical area is external, the medullary area is internal. It's a recurrent theme. Same with the kidney anatomically. Get used to those terms. And what's interesting here, where on nails, the cuticle is an area that we're all familiar with on the posterior margin of the nail, different in here, it surrounds the hair more as you will see. And so it's kind of, you see it springing from the inside, and you're going to see layers that surround it externally. So the viable portion, so to speak, is inside, as you'll see from the diagrams. And again, the aromelanocytes is different combination that make different hair colors that are there. Red hair has this particular pheomelanin, then it's fairly recessive. I mean, you may know, even when I was a kid in school, I remember a whole lot of kids that were naturally redheaded. We had a few that were there. I mean, if you go to England, it's very common. England, Scotland, redheads galore. Just watch Premier League soccer. It's a redheaded festival. So they're obviously genetically oriented to the point I'm making. That were there. My kids had I remember the guys came from England when my boys were playing soccer. And had summer camps, all red. Hysterical. Love them. And gray and white hair results from melanin production decreases, and it's not a different pigment, it's air replacing melanin in the shaft. That's what creates, and it happens at all different ages. My wife had dark hair, went prematurely gray, and then colored her hair, and it was she went prematurely white and colored her hair, and then stopped coloring her hair because the white it's brilliant. She has great looking hair. She doesn't have color. Everybody's like, "Where'd you get that color?" Because it went. I still, when I see pictures of her before her hair color changed, something. So here you can see the cuticle. Here you have cuticles surrounding this internal area. Okay. Here you can see the medulla being the internal area. So inside there's cuticular materials here that give the hair a certain amount of material. Here it's growing from, and here's the base layer. And here it's growing externally in sort of a radial aspect. In a sense, it's going in all directions equally. And you can see the enclosure that was here where it's still viable. Connective tissue sheath, there's a glassy membrane, all of these different things. And the last thing I'm ever going to have you do is label a diagram about that. I don't want to get that. Truth be told, if you were in a cosmetology class, we'd be talking all about it. But I don't know a lot about it, and it bothers me when we talk about here. If I make a joke, and the rest of you just ignore it. You'll see one day it's going to happen to you. So the hair bulb, that's where things are starting. And so if you're going to relate to things where the growth area is, the follicle area and the bulb itself are really where we see growth going on in here. That's the same. It's the location, just like you would think of the stratum basal or stratum germinativum. That's there. You can see the connective tissues that sheath around it. Okay, all these different structures that are there. When we're looking at that, that's the root area of the hair. You're going to see the name for that when we get to the nails, called a matrix. Okay, and so that little white area on a nail we call the lunula or lunuole because it's moon shaped or half crescent moon shaped, and it's on toes as well as fingers. That white area being unpigmented, if you go right, that area effectively is where the matrix is located. Yeah, nail I know a lot more about. So the matrix area in both, deep within that follicle and in that bulb, are where it's actively dividing. That's where it pushes out the older ones. Erector pili is the smooth muscle, goosebumps, gooseflesh, whatever it is. That's a function that occurs during our autonomic nervous system and fight or flight. We'll learn about that in physiology. No, we don't do that unit. We don't do autonomic because it's much more of a physiological system. But we'll look at the neurotransmitters that are responsible. The dermal tissue called the papilla, containing a knot of capillaries that supply the hair. Again, it's analogous to the skin, hence the name skin appendage. And frankly, that's dermatologically, they're intertwined. So we typically, my field involved much more treating the skin and nails. There really wasn't much you could do about the hair that was there. We looked at hair growth when it began to no longer grow. Then you started worrying more about it. It was a sign of circulatory embarrassment. Things weren't working. Here's the schematic. Here's the follicle. So you can see here within, this is the connective tissues. This is its life supply. Here you can see melanocytes that are surrounding it, imparting the pigment, different types, the papillary area, the matrix area where it's beginning to actively divide. So these are the base cells, and now you're going to see the dividing. You're going to see that sort of cuticular area centrally placed. And you see it's going in all directions as well. And here's the sheathing that you're starting to see surrounding at that area. You have an internal and external root sheath made of different types of connective tissue elements. Until finally what protrudes is the shaft. Here's the actual microgram. And again, not going to play label. I don't play label the diagram with this. We do more label the diagram when we get to the nervous system and muscle system, not so much here. Different kinds of hairs. There are actually three. One is more of a hair that's associated at birth. They don't mention here, it's probably a good idea, it's more embryological, and during birth and growth and development, it's called lanugo, Lanugo. There's like a layer of skin that some babies are born with that has a lot of external hair on it that sheds. It's somewhat frightening for parents. Okay, and they see that it sheds, and typically there's no problem. Sometimes there's occasional genetic problems associated with it. The most common ones that we see are in children and in women, very pale, very fair hairs called vellus hairs. They're not easy to see. They're there. We can feel them. They're not necessarily as prominent. And when we see terminal hair, those are the typical, when we talk about hair, it's a terminal hair. It grows, it's coarse, it elongates, and then we get terminal hairs at puberty that appear, as you can tell, axillary and pubic areas, facially and neck of males. There's variations. I mean, some women cosmetically get some of the hairs in areas that are cosmetically, I'm going to be kind, unappealing. And there's steps you can take for that are done sometimes similarly permanently. Like I said, my daughter, can I tell you, was an esthetician? Did I mention that? Yeah, I mean, she actually managed. She was trained in all that laser stuff and all that, but she managed one of these places where, in a wealthy suburb around here, where she had to write $60,000 to $100,000 a month of business, where rich ladies came to do Botox, as you can imagine, that type of stuff. And she was pretty knowledgeable about that stuff. I mean, so I have a little input from her. So they kind of, those classes sell you a bill of goods, because even though people do Botox who inject it who shouldn't, it's supposed to be injected by no less than an RN or a physician's assistant or a physician. My daughter having a couple of month course showing her how to do it doesn't mean she should be doing it. Nor did she ever do it. So kind of like, okay, point taken. So all of those things, those kind of places, for the people who are the fronting of the places, they hire attractive gals, so it's sort of a magnet to people who are so appearance cognizant, like me. You see all the Botox. Okay, different things affect it. It doesn't, there's not a lot of growth, comparatively speaking. I mean, just like anything else, we lose a certain amount, can't help it. And as you can see, 2.25 millimeters of growth, not a great deal. So what does that boil down to? 2.54, 25 millimeters, 2.54 centimeters in an inch. So figure a tenth of an inch per week. And some people's hair grows faster. There's enough genetic variation. It's not going to grow back fast. Okay, here we begin to see this. When we get to, I was talking about adrenal glands, this is the adrenal cortex, the only place where women normally make male sex hormones, which play a role in replenishing red blood cells, which play a role in sex drive, okay, called androgens. And that's where a lot of the shenanigans, kind word, of where we're seeing anabolic steroids come from, that area. Now a lot of human growth hormone. But tumors of these can have abnormal amounts of androgens. And so polycystic ovary disease can be one of those things that relates to that. Excessive hairiness, a fancy name for anybody who's hairy. And even if you're describing someone who's not excessive, but more normally, you'll say hirsutism. But hirsutism is excessively hairy. Masculinization we associate with the women. And a lot of times, again, it's not a big deal. It's more of a cosmetic thing than anything else. Stop calling. Love. My wife's great. She found something we had to find. I looked this morning and things like that. And so there's nothing unusual about that. My first wife had, one of the reasons she was unable to conceive, she had polycystic ovary disease. Okay. I mean, that was part of the panorama. That's just, when we get to physiology, we start talking about male and female repro. I know a lot about what goes wrong. Okay. So, and that's how you kind of reverse that and say, if this didn't go wrong, then what goes right. So you have a lot of stuff with that. Having report she's doing well. She's had a lot of health problems. Unfortunately, I'll tell you about him when we get into certain aspects of how, things that impact stress and things like that. Her brother died on Thursday after a long illness. He's been like in a nursing home for a while. Interesting guy. He was a 9/11 operator here in the city for many years. Got written up in the old Post. We had what called the Pittsburgh Press in the evenings, Post Gazette. He had a write up, and then they merged 25, 30 years ago. And he got a write up in the press for saving somebody's like on the 9/11 calls. Really a good guy. Fortunately, the stress was so much. Every night they came back to around where he lived and drank. Sometimes high stress jobs. Beware those of you going into medical fields and things like that. There's a lot of stress in medical fields. A lot of people turn to alcohol and drugs. I'm not being critical. I'm trying to be like that. He unfortunately had all his hair. So did his dad, my wife's dad, my ex-wife's dad. So baldness genetically determined. A lot. Sometimes it is sex influenced. Sometimes it's related to things like they talk about tied to DHT levels and male pattern baldness. There's so many things. A lot of baldness is sex related type of hormone. It comes from the mom rather than a dad. Okay, that's there. And I said my baldness is all over on my dad's side of the family, but my mom's, go figure it out. Her dad, when he died, when he was only 70 years old, had a whole head of hair. Still mad at her. She had always had it. Why did I get that gene? I'm also mad at the whole gene thing. I had two male cousins. One unfortunately died relatively young. They were the sons of my dad's twin brother and sister. She was very tall, 6 feet tall. Lady. He was not. He was my height, 5'8", 5'9". Both of their sons were 6'3" or 6'4". What happened to me? I am vertically challenged. I have looked at those height weight charts. 5'8" and a half, full torso, okay, 170, 174. I should be 6'6". I'm vertically challenged. I'm not. It's a height thing. I demand a recount. Dad was 6 feet tall. Awful. Nevertheless, here's some of the things that do influence it. If you did not know, stress. One of the things we see when I did derm clinic, the oldest hospital in the United States is Pennsylvania Hospital. It's in Center City, Philadelphia. Assuming it's still, they've probably been taken over by something. Wonderful teaching hospital, all that good stuff. We were tagging at a derm clinic when we were senior students that were there. And we saw a lot of what's called alopecia areata, almost exclusively in women. It's circular patches of baldness that just would develop. And inevitably, they were stress related, hormonally related, okay, crash dieting related. There were so many things like that. Every time I see one, the dermatologist, whoever was either a resident or the attending, would come and tell us, can't figure, they were injecting them with steroids. There wasn't a lot of treatment. It was basically steroids and, trying to, basically treat the patient more holistically. And then other things like that. All sorts of medications. If you did not know, a lot of hair loss occurs with the SSRI category, selective serotonin reuptake inhibitors, the Paxils and Prozacs, these ubiquitous antidepressants that they keep changing, but they're effectively in the same thing. They tend to, one, begin to change in the pubic genital area. We see pubic hair loss. We see lack of sex drive, things that are associated with it. Okay, dryness in women. All those things there have been significant problems with that. How they differ, side effects. Some better for kids, some better for adults. some to deal with those kinds of problems. It's a very interesting subset, but still used rather a great deal today, if you did not know this. And so thyroid activity influences everything. If you're deficient in proteins, it's going to do all that. Sometimes you just, we typically attribute it sometimes to medications or heredity. Nails, same deal. Scale-like modifications, hard keratin, they're much more along the lines of protective. If you did not know, underneath your finger and toenails are a number of clusters of nerve and vascular tissue. They're little neurovascular bundles, tiny blood vessels with almost like capillary beds with arterioles and nerve bundles. It's got a famous name you don't have to learn called glomus body, Glomus. They are little sensors for blood pressure. A lot of that basically sends signal to your brain going, it's very cold, it's very warm, make alterations. They're extraordinarily painful. It's one of the reasons when you smack a nail, get it caught hammering something, blood accumulates. They're very vascular. Blood accumulates a lot. How much pressure is it under? I will give you the anecdote. I had a patient in a chair came to me. He dropped a steel barrel at work on his foot. Worked in the industry on his big toe. Okay, oh my God, I've never been in so much pain in my life. And so I took off his shoe, the big toe, totally black. I tried to go near it. I do something now. Basically, in the emergency room, they have something called a thermal lance. It looks like like a hair trimmer, what I would use for my mustache. It's plugged in, you hit the button, the tip glows. It's got like two little wires that glow red hot, and you push it into the nail. They're expensive. I was just starting in practice. We used a time-honored technique of unfolding a paper clip and eating it with your lighter. And I did that and lanced it, and it shot up. He's lying like this from his toe to his forehead. Like, psh. Honest injury. I tell you, these are real stories that happened to me as a clinician for years. This was early in my practice days. I almost did one of those. I didn't expect it. I said, and the relief instantaneous, absolutely instantaneous. So, oh my God, I'm getting embraced. It's okay. It's worth. That means it worked. So here are just some of the things that are there. The free edge of the nail, what we trim. The nail plate, the nail really is the part that covers before it reaches the free edge. It's covering a very sensitive area. The skin underneath your nails is called the nail bed. It's modified skin. If you lose a nail, because you hammered something, you got it caught, you whacked something in the middle of the night going to the bathroom. All common things that cause people to lose nails. Gets caught on something like that. That bed will harden and toughen temporarily and take the place of the nail. As the new nail grows, it will cover it up and it'll soften again. The only time that doesn't happen is if the damage was all the way back to the root or matrix under that lunule, which you will see. So the nail bed is epidermis that's very keratinized and can be more so and take the place. The matrix, thickened portion of the bed where it's growth and typically less vascularity. When we would permanently remove nails, ingrown nails, things like that, we would cauterize that. I did chemical cauterization, thousands of procedures. Not joking, thousands. Okay. The folds are the skin that surrounded fingers and toenails. The cuticle, epo means to the outside of. Nicium is obviously the prefix for nails out here. Hyponychium is under the free plate. The dirtiest part of your body vis-a-vis treating patients, which you want to get clean, which will come in contact with them under your nails. The whole idea of surgical scrubbing is get your nails and fingertips clean enough so you can don gloves. You're touching a sterile glove on the non-sterile surface, the surface that's going to come in contact with you. That's what surgical scrubbing is all about. If you want to have fun with it one day, we'll go into the lab in physiology. I'll show you how to properly scrub. We have sterile scrub brushes, put betadine or you'll put betadine on it or Hibiclens on it, and those are the two agents that we use in the hospital. And have a scrub party. I do that in microlab. You tell my wife, clean hands and a pure heart. I'm halfway there. You're worse than the comedy club night. Not working. I was going to try either my next 25 years, this is about 25 years teaching, I was either going to try being a chef, do the comedy club thing. I think I'm heading back to the kitchen. And see that? I got a smile out of that one. Half a grin over there, chuckle here. Jen is still not responding. I know. Tough root, no Steelers home. Abnormal color or shape can be an indicator of disease. Nails are one of those areas. I had a textbook, no idea where it is now, that talked about all the different nail diseases. There's certain things that are mirrors of systemic diseases. Your mouth, the best. You stick out your tongue for a lot of reasons. Looking at your mouth shows there's so many clinical signs. Nails are like the clubbing of the nails, bad circulation, respiratory problems, discoloration, that whole squeezing thing with circulation I was talking about, extraordinary. If you're not doing that and you're examining circulation, not just in a diabetic, in anybody with compromised circulation, you're not doing your job. Okay? So all those things here are the thing. And it's just like this. That's the nail bed. Here's the nail sheath. Really, and this is where the matrix area, here's that cuticle or luneal. This is all matrix area. They depict it farther back, and it sits right the heck on top of the bone. And that's a big problem that someone like that guy is telling you about. When you drop something heavy like that on a nail, boom, when that nail comes off, you're seeing this clinically, or if it's somebody in your orbits, you or somebody else, look to make sure it's not slit, that it hasn't, that the skin and that nail bed, because all that's underneath is bone, and that, as you will learn, is an open fracture. And that's something that you must get treated with antibiotics. Probably must get treated with, make sure your tetanus is updated. Not, you are really risking a big problem. There's not even a question about it. We'll talk about a little bit in that contest with open fractures of tetanus and non-tetanus prone wounds. I'm not guessing that you did that in micro and things like that. If you start to laugh at any of the jokes, I will give you my handouts on this. If you do not, I can be vindictive. What are they going to do? Fire me? Wife, we're looking at a way, it's like four people can buy really nice RV and sort of share the expenses over X number of years and sell it. So we can each get it for like 13 weeks. We're traveling around. Go ahead, make my day. So, yellow tinge, respiratory or thyroid, thickened, fungal is pretty common. That's not really that's not something you're going to lose your life to. It's just more cosmetic. Spoon nails, iron deficiencies. That was one of the first one we learned about. We had a professor who was, as leading authority, he wrote a textbook with all. It was his textbook. I'm trying to remember his name. Dr. Krauss. So he may have been the leading authority on nails around. And Bow's lines, if you didn't know it, I had patients where the nail, heart attack, loss of a loved one, significant diseases, you'd see a line across the nail, finger or toe, and you could almost mark what happened. If you knew the patient well, all of a sudden you could see, now it's starting to grow out. You could see how long ago. I mean, typically it takes a year for a toenail to grow out, 9 months to 12 months, maybe younger, a little quicker, and maybe 3 to 6 months for a fingernail. You could map it. So if you knew the patient well, when they had the heart attack, when their spouse died, when there was a terrible accident or something like that. Honestly. Voila, there's that koilonychia. See? And then glands we did before, they're all over. And notice, except nipples and parts of the external genitalia contain sweat glands. So they're nearly everywhere that are there, millions. Eccrine, again, when I did that one before on the board, Eccrine or merocrine are the typical sweat glands. The apocrine are the ones that we first noticed at the time of puberty, as we begin development towards sexual maturity, typically in the axilla and in the pubic area. Okay. I mean, their epithelial cells, will stimulate them to make more perspiration at certain times. Again, people end up perspiring. Some people do a lot, some don't, as much as you would think. The eccrine are the most numerous: palms, soles, forehead. Okay, and that plays really, and again, an important role vis-a-vis fingerprints and things like that, or footprints. And those two are as distinctive as fingerprints, as you might guess. Okay, thermal regulation, certainly. As you can see, all of the things, there's a fair amount of different wastes. Okay, microbicidal things that are part of it, metabolic wastes that are there. So it's interesting how all of that. So it's really a pivotal part of our defensive system and even our excretory system, if you want to think of it. It's there, and they're just showing you where they are located. The apocrine, axillary anogenital, it's a little different. It's got a little more of an oily component, but still liquidy. Bacteria break it down. Body odor is you can take someone hygiene plays less of a role than you would think. Some people are unusually prone to it. Some people are not. Okay. It just depends on how much they perspire. Oftentimes, that's not discounting the hygienic aspect. If someone has poor hygiene, or you're talking about homeless individuals, it's a whole different world. For those of have the luxury of being able to bathe and shower and change our clothes and wash our clothes regularly. Okay. They're really associated with hair follicles. Yeah, maybe so. When we think of that sort of sexual scent type of thing, I don't know. Because I don't think it's present in everybody. The earwax, the ceruminous or caruminous, depending on how you pronounce it, glands, earwax and mammary glands. So when lactation occurs, the consideration is it's not so thick that it's still in a liquid phase, but with proteins and fats. That's why most authors are fairly confident of them being apocrine glands. Where if you looked at the unit on glands and talked about apocrine glands, well, maybe they don't exist. Who then? And so don't trust the PowerPoints. Read the material, and if not, there's so many areas you can look this stuff up online. The basic AI on Google and stuff like that. Yeah, I'll plug you into articles that are significant, not just Medline or things like that, or Mayo Clinic. Not that they're wrong, but you can look deeper into it because I have a lot of scholarly articles and things. And that's really what you should be reading at this stage of the game. Well, everywhere, but except for thick skin of palms and soles, because we don't have any hair there for the most part. Okay, secrete into hair follicles. Again, not as much as puberty. Oily, bactericidal, softening, and the amount that we produce is different. It's just different. There's so many different hair care products. They're tailored to the kind of hair that you have, and a lot of people are very aware of that. I am not. I was always, hey, my first wife would buy every type different one that she thought would work better, and I never had to buy any. She'd stop using it. A useful summary. Aha! Acne, inflammation of sebaceous glands, pimples, pustules, cysts. I think it is going by a different name now. I'm going to have to look that up. It's not microclass. I'm not going to ask you about it. Propionibacterium are part of what are called diphtheroids. Diphtheroids are normal flora. They are gram-positive. They should be familiar. Non-endospore forming rods. Okay, anything that's not like that we classify as a diphtheroid because they look like, but hopefully are not, diphtheria. Okay, which is a dreaded disease. So they're in this. There's something you'll see on a lot of, if you do skin sampling and surface sampling, you'll see them. Microscope, you do just a generic gram stain. They can either be whiteheads or blackheads, and that's blocking that sebaceous gland. And then inside, that's where in certain people, that oil, enzymatically, you begin to break it down and it becomes inflamed. If you have enough of these Propionibacterium acnes, effectively, it's an inflammatory hair follicle that's really starts to swell and can, when it breaks down, it can become infected by other bacteria. Nasty. Most of the treatment for years was, and still is, as far as I know, basically using vitamin A acid, all those different types of over-the-counter remedies, and even back, and maybe they still use the Accutane today, which are people with very, very severe acne. Has a lot of side effects, dangerous. For severe, my stepdaughter had in high school. I don't know if I told you about that. It's like super concentrated, and they gave it to her, and initially it forces it out, and it actually makes it worse at first. So much so, she had to get a blood test before she could pick up a prescription that day to make sure she wasn't pregnant. And it also associated with suicidal ideation. So, I mean, your acne, that's, you're using that if it's so severe, it doesn't respond to the commercially topically available products that were there. I was lucky that I didn't have that particular problem. People did. Okay. My kids, I don't recall having any. They're not. I have no genetic relation to them, nor they to each other, so I really can't comment about it. So Seborrhea is a little bit different. They're overactive. They call it cradle cap. Okay. Most of the time, it comes off. There's some topical measures, which you see on me. Some of the things we get older, you get what are called seborrheic keratoses. They're part of aging. They're there. So sometimes they look worse than they are. So when my family doctor, who I saw on June 30th, my PCP looks at it, he goes, no, they look the same as last year. See, if they start to change, or my wife said that looks different, because it's hard to see it on yourself. That's when you get them looked at. Just the way to. So you're very clinically. We take pictures, put them in the chart. Nowadays, you would do it digitally. We had a Polaroid that had, it actually had a little frame on it. You could put it on the part. Typically, you would take a small, like we use in the micro lab, those small rulers. Anything that had a ruler on it, scalpel blade, something that would give you context for how large it was you could measure and see if it changed from year to year. That's the appropriate way to do that. Anybody going clinically with digital photography today, slam dunk. Easy to say. Here you could lose the Polaroid. That's the cradle cap. And here, protection, body temperature regulation, sensation. It's a little bit of everything when we get into the functionality of it, which is what this is. And I'm sure we'll end up finishing up because it's easier in the lab to do burns and rule of nines that are there, which is part of it. The cancer unit doesn't take very long. It's there, protection, body temperature, cutaneous, they'll do all of this. Okay, multiple barrier. All the chemicals, perspiration, filled. You saw that list of chemicals it had on it. It's salty, bacteria, microorganisms, short of Staphylococcus, hate salt. Okay, they're halophobic, Staphylococcus. We cultivate, that was that MSA agar you used in micro. So now you begin to see the physical is clear. Biological, they give you one here, really biological, is because it's covered in microorganisms that are covering up receptor sites that bad guys can't latch on to. They're your good guys. They're there, your immune system sampling it all the time. That's why we get into something we talk about immune called the hygiene hypothesis. It's kind of why, I'll get into the stories with Henry VIII and his one. He went through a lot of wives to have a son. We'll get into it. Love tutoring. There's a new Dan Brown book coming out. He's the one who wrote the Da Vinci File. He published about every 2 or 3 years. He does a ton of research. That's coming out at midnight tonight. 688 pages. I'll be engrossed. Love that stuff. Ken Follett's got a new book coming out too. In love with England, old England and stuff like that. Just in love. It's called reading. Lord help me. So all of these things, antimicrobials, sebum, is defensive in nature, cells, another defensive thing is what happens. The acidity comes from the breakdown. Remember what the membrane is, it starts to break down. Okay, phospholipid bilayer. Remember what it's filled with long chain fatty acids, acid mantle, melanin against UV radiation, affecting DNA, physical, all the stuff that's there, glycolipids, so it's waterproof, shockproof, hard to puncture. I mean, it's hard to jam something into somebody. That's why they don't make needles dull for a reason. Or surgical instruments, it is hard to get through. Lipid soluble because of the fact it's mostly a fatty barrier, and effectively it's porous. Once you get through it, it will pass through. Okay, not water, and that's where smoking patches can be utilized. It's a very predictable way of getting medication into somebody. Now, the most infamous, that when we didn't have them when I was in practice or they were in infancy, were fentanyl patches for pain management. Okay? And really, they're reserved for people with end-stage cancer and things like that. You can predict the usage of those kinds of things. Seasickness patches has been around, scopolamine for years. Poison ivy. It's a resin. Resins are fat soluble. It takes time, and so what it is a delayed reaction, hypersensitivity. That's why poison ivy doesn't show up. If it comes out when you just come out of the woods, it's an allergy. If it comes out 48 to 72 hours later, it's poison ivy. This is one of the problems. In chemistry, I'm sure you wear gloves, all the get up, right? In there. We didn't. No masks, no gloves, no hoods, no nothing. I was a chemistry major. We work with picaridine dyes, which are highly, and you get a DMSO on your hands or acetone right through. I'll regale you with stories of me sticking my bare hands inside of people to stop bleeding. It wasn't like on TV. All those ER shows where they're all together. That wasn't mandatory until 1994. We had our lab coat on, scrubs. That was it. You only put gloves on when you're going to do suturing, stuff like that. Somebody came in, bam, right here. Sorry. Keep your skin intact. So heavy metals can get through there. They're toxic. Nitroglycerin is another patch that was used traditionally. And other things, we know how to bring these things in. So that nicotine patch, a lot of people use. Some people feel that's effective against COVID. Like small doses of that, cutting one patch into 4s and wearing one of those every day. I mean, there's some evidence that scientifically. Biologically, yes, they're talking about the cellular basis. The dendritic cells, those ones that the Langerhans cells that are really antigen presenting cells. The dermis itself obviously has a lot of white blood cells. To me, that barrier, biological, is more the bacteria that cover it. But I mean, all of those types of things. And again, DNA can absorb. The problem with it is exposed to too much ultraviolet radiation. Now we're dealing with potential for skin cancer. Okay, all of these are the bad things that could have happened to us. Okay, all that type of things that are there. So and you'll find out as time goes on and as we talk about this stuff, it's a matter of degree. How much exposure over how much time? Your body has ways of taking care. If it's limited exposure for a limited amount of time, then you have a fair amount of recovery time associated with it. It's chronic. It's like people in industry before we had health regards. I mean, I worked in rural northwestern Pennsylvania for 25 years in Oil City, Franklin. Everybody had industrial jobs before they all disappeared. I mean, I used to come home and go, I can't believe what percentage of my patients have cancer, either active or historical. I just go, all those chemical plants. You go through there on your way up to Titusville, you couldn't breathe. Okay. And so Pennzoil's refineries, Copper's chemical plants. Oh my God, glass plants. So care, should never be touched with bare hands. Here's the idea. Insensible perspiration, 500 milliliters a day. We get rid of a half a liter with perspiration. When you have sensible, means you can feel it. And as you can see, it can be quite a bit of liquid that comes out. Okay, and if you're like me, I perspire very, very easily. Sure. Just the way it is. And so as you can see in the cold, the dermal blood vessels constrict. Okay, slow it down. That's just a lot of receptors certainly are there, free nerve endings. I'm just reading it to you. Same illustration you saw before. You can see where all these things are. We go into these in some of the sensors. The deeper they are, the deeper the sensation. The ones that are up here, light touch. As you start getting down there, you get deeper touch. You get to these what are called Pacinian corpuscles, which we'll get to for vibration and things like that. Your skin is an endocrine organ, which means it deposits chemicals called hormones directly into the bloodstream. In this case, it's part of the activation of vitamin D. In order to have vitamin D, which means to have healthy bones, you have to have exposure to sunlight. And it's got to be direct sunlight. Being shut in is not direct sunlight. Having all the windows, having it coming through like we are here, not direct sunlight. Fill the blinds, not direct. Got to be out in the sun. Big problem for elderly people who are shut in because they're insecure, particularly in cities. We see a lot of that. They're very afraid to go outside or anything along those lines. And so keratinocytes do conversion, cortisone agents. Skin makes collagenase, a natural turnover to prevent wrinkles. Collagenase has been known about and utilized in wound care for a very long time. I was working with a doctor who was starting some of the early wound care techniques using collagenase to take care of wounds and remove debris, etc., in the very, very early days. So I know a fair amount of this. It's a blood reservoir, 5%, and it can move it around when we're exercising. That's the beauty of our bloodstream. I would say it's 5 to 10%. That's there. And certainly lots of things, nitrogenous waste, which are mostly through the kidney. We lose some. Ammonia, urea, uric acid, salt and water, certainly with profound sweating, etc. We'll pick up with, I'll finish up the cancer and the burns, and then we're into that unit, and we'll be well into bones, which we'll devote the lab to after maybe the first 20 minutes. Thank you. I have bones out for your viewing pleasure. What fun.